just wanted to make a note for the folks that are online. We're waiting for a few more folks to return from lunch and we'll get started. I'm thinking we'll I don't know how many people have returned from online, but you guys are missing what's in the room. There's a skipping contest.
No, you couldn't do the skip. Last song was skip. Back into the backpack on your microphone, right?
How about jumping rope at the next break, Shay?
No.
Okay. There you go. All righty.
Thank you all for your participation.
Yeah, thank you, Shay. Appreciate it. I think we're going to try to get started. I know there's still a few folks that are out, probably finishing up their lunch. I wanted to take a moment before we introduce our next session to give folks an opportunity, if you're not a speaker, if you were not on the resource panel, just want to get to know the people in the room, the folks that have attended. I'm going to ask if you would just go to the microphone and introduce yourselves. I'm looking at the attendees, if you don't mind. It is great.
Good afternoon, everyone. My name is Nicole Barton. I am an environmental health and safety technician at Winslow Indian Healthcare Center, and that's in Arizona. Thank you.
Great, thank you. Yeah, appreciate it. There are others? Don't be shy.
Good afternoon. My name is Edward D. I'm also from Arizona. I'm working with Navajo Nation legislative under policy, dealing with environmental health and sustainability.
Great,
Thank you.
thank you, thank you. Others?
Scanning everybody. My name is Carol Fisher and I'm from the Seneca Nation, just outside of Buffalo, New York. And I'm a public health technician for our Seneca Nation Health Department.
Great, thank you. All right. Any others? While we're waiting on others in the room to come. Rio, I'm going to be looking at you on deck to see if there are
Hi,
folks
everyone.
online.
My name is Jerome Staub. I'm the Community Partnerships and Engagement Consultant for the state of Kansas, Santee Sioux.
Great, thank you. Welcome.
Good afternoon, everybody, and welcome to Oklahoma. And I hope it's been treating everybody well if you're from out of state. I'm Jolie Stone. I'm the state epidemiologist from the Oklahoma State Department of Health. So thank you all for having me. And but I hope that you're enjoying our hot, beautiful city.
Thank you. We are.
Hey, good afternoon, everyone. I'm Stephen Weaver. I'm the tribal liaison for the State Health Department here in Oklahoma. So we appreciate the invitation to be here and listen and learn. So thank you.
Thank you. Appreciate you coming.
My name is Erwin Nanashi. I'm here from Oklahoma, and I'm with the Oklahoma Conference of Seventh-day Adventists representing Native Ministries.
Thank you.
Good afternoon. I'm Andrea Bryant with Southern Plains Tribal Health Board right here in Oklahoma City.
Welcome.
Hi, good afternoon, everyone. I'm Nestoria Wright from Kickapoo Tribe in Kansas. I'm the Environmental Health Director.
Great, good to meet you. We are taking a little bit of time to introduce the folks that are in the room that are not either a speaker or a presenter, but that's okay. Come on in.
I might
Summer?
actually be a speaker. So
That's
my name
okay,
is
but we-
Summer
we'd love
King.
to introduce you. Summer?
My name is Summer King. I'm the senior environmental scientist for Quapaw Nation, and I'll be speaking tomorrow on Quapaw Nation's work on the Tar Creek Superfund site.
Thank you. We're glad to have you. And there may be some others that are not back from lunch. And maybe we can grab them at the end of the session today. Rio, I'm looking, are there any folks online? You want to come up and introduce them? Can you bring your computer that far? If not, we'll make sure to introduce them before the session is over. I'm sorry? Oh, okay, it's a phone number. Okay, got it. Okay. Yeah, and if you're online and you would like to leave your information, so we can make sure that we follow up with any issues, concerns you may have, it's just your choice. All right, well, welcome back, everyone. Hopefully everybody had a good lunch. I know some folks went across the street, which was really across the street. And you made it back in one piece and through the heat. Okay, next on our agenda, we're about to hear from Dr. Rachel Rogers. Rachel is a senior environmental health scientist at CDC's National Center for Environmental Health and the Agency for Toxic Substances and Disease Registry. She is in the Office of Science and serves as the scientific lead for the National Center for Environmental Health, ATSGR PFAS, and we'll talk about PFAS. We lovingly use that acronym, Community of Practice. She has been with NCH ATSGR since 2008. And if you'll note on your agenda, PFAS, per and polyfluoroalkyl substances. This is that session that we're about to embark upon. We use the acronym commonly PFAS, or man-made chemicals, also known as forever chemicals, that have been used in industry and consumer products worldwide since the 1940s. They've been used to make nonstick cookware, water-repellent clothing, stain-resistant fabrics and carpets, some cosmetics, some firefighting foams, and products that resist grease, water, and oil. During production and use, PFAS can migrate into the soil, water, and air. And most of these chemicals, various classes of PFAS chemicals, do not break down, so they remain in the environment. Because of the widespread use and their persistence in the environment, PFAS are found in the blood of people and animals all over the world and are present at very low levels in a variety of food products and in the environment. Summit attendees, that's you, will learn about CDC's effort to mitigate the effects of PFAS and how PFAS have impacted tribal communities. So without further ado, I'll ask our very own Rachel Rogers, Dr. Rogers, to come up. Thank you.
All right. Hi, everybody. Can you guys hear me okay? Great. Okay, well, welcome back from lunch. I hope everybody is awake. Like you just heard, I'm Rachel Rogers. I'm a senior health scientist at ATSDR and the National Center for Environmental Health. Officially, I sit in the Office of Science, but I am also the technical lead for the center's PFAS Community of Practice. And in that capacity, I provide technical oversight for all of the PFAS work, the entire PFAS portfolio going on across the center. I've been working on PFAS at ATSDR for over a decade at this point. It's basically all I've done. And I care really deeply about the work that we do to support and serve communities that are facing PFAS contamination. So I'm so grateful for the opportunity to be here with you guys today and to be able to talk about PFAS with this particular group. Okay, so I'm going to start with just a little bit of an introduction to ATSDR. I know some of us in the room are probably very familiar, but it's a bit of a mouthful as an acronym. And so I just like to give a little overview of the agency to start off with. And then we'll jump right into what PFAS are, why we care about them. And then I'll talk a bit about the work that ATSCR is doing around PFAS and some of the resources that we've developed to help support communities that are facing contamination and who have concerns about PFAS exposures. Okay, so before I launch into the technical stuff about PFAS, I do want to say a little bit about ATSDR. We are the Agency for Toxic Substances and Disease Registry, and we are a federal public health agency that is within the Department of Health and Human Services. We share leadership with the National Center for Environmental Health, and we are a sister agency of the CDC. So our primary mission is to help identify and reduce exposures to hazardous chemicals in the environment. We do that by engaging with communities to see how people are exposed to chemicals and to assess whether or not those exposures pose a risk to human health. So our goal is to help protect the public from the adverse health effects that result from exposure to chemicals in their environment. We do this by responding to emergencies, by investigating emerging concerns. We do this by conducting research and by building capacity. Ultimately, our goal is to reduce morbidity and mortality related to exposure in the environment. I'm just gonna rearrange here for just a minute so I can actually see the slides. Okay, cool. Okay, so we get requests for support from federal partners, from state, local, tribal, territorial partners. We get requests for support from individuals and from community groups. And when those requests for support come in, one of the first things we do is assess the available data about the exposure that's occurring, as well as the public health effects. From there, we might do a variety of things. We might go collect additional data. We might conduct a study. We might make recommendations to other agencies, the EPA, for example, to help reduce exposures and protect public health. Ultimately, we work hand in hand with partners across the United States at all levels of governance and with community members themselves. ATSDR is headquartered in Atlanta, Georgia, so that's where I'm from, and we share space there with the National Center for Environmental Health. But we also have 10 regional offices that you can see here on the map, and those regional offices are co-located with our EPA regional offices. Our regional offices are really the front line. They are the front line for the work that we do in communities. Our regional reps serve as liaisons between ATSDR headquarters and our partners across the board. Because they're on the ground, they're actually in the communities that we serve. Our regional representatives are absolutely critical for developing relationships and getting the work done, for facilitating the programs and for conducting the activities of ATSDR out in the world, out in these communities. So with that out of the way, let's talk about PFAS. So the first thing that I want to start with, and Sharendra alluded to this already, but I just want to start with the acronym because it is a very weird acronym. PFAS stands for per and polyfluoroalkyl substances with an S at the end, but it sounds like one chemical, and you'll hear people talk about it like it's one chemical, PFAS. When in reality, PFAS is an entire class of chemicals. It depends on who you're talking to and what definition they happen to be using at the moment, but the general consensus is that PFAS, the class of PFAS, includes over 9,000 different chemicals. By and large, chemicals in the class are characterized by a carbon chain that is either partially or fully fluorinated. So where you would have a hydrogen atom bonded to the carbon, instead you have fluorines. And you can see an example of that here on the screen. The carbon-fluorine bond is one of the strongest in organic chemistry, and because of that, PFAS have many unique properties. They repel both water and oil, and they are particularly well suited for use as surfactants and dispersants. You will find them in certain kinds of firefighting foams and in a variety of different consumer products. PFAS are also remarkably persistent. So when they are released into the environment, they don't break down, they don't degrade, they tend to stay there. And when they get into people's bodies, they don't really go away. They bind to proteins in the blood and they just stick around circulating through the body. So this schematic illustrates some of the ways that PFAS can get into the environment. And you can see that there are a lot of ways. Starting kind of top left of this graphic, facilities that actually make or use PFAS, so manufacturing facilities, can discharge PFAS directly into surface waters or onto the ground. In some cases, they also discharge PFAS as a part of their waste stream into wastewater treatment plants. Wastewater treatment plants can discharge PFAS into surface waters or into the environment. They also, this doesn't happen as much now, but historically, wastewater treatment plants have provided contaminated biosolid sludge for use as soil amendment on agricultural fields. And so when the PFAS is in the biosolid sludge, it percolates down into the groundwater. It's a problem. And so all of these ways, through all of these pathways, PFAS end up in rivers and in lakes and in aquifers and in our drinking water ultimately. Ingestion is the primary PFAS exposure pathway. They're typically found in places where PFAS are either made or used. I've already talked about drinking water. I'm going to talk a lot more about drinking water, but we also know that PFAS can be found in food or animal products that are grown or raised in areas that have PFAS contamination. So we see PFAS in fish that are caught from waters that are near PFAS manufacturing sites or places where PFAS have been used. We also see PFAS in things like cow's milk from dairies that are near PFAS contamination. People can be exposed to PFAS in the soil and in the dust. They can be exposed to PFAS from the use of certain consumer products, from eating food that has been packaged in materials that contain PFAS. So PFAS repel water and oil. They have historically been used in food packaging materials. Think about when you order a pizza and there's that piece of paper under it that gets really greasy, but somehow doesn't fall apart. Maybe not as much today, but in the past that may have been because of PFAS treatment. We also know that babies that are born to mothers who were exposed are exposed to PFAS both in utero during pregnancy and through breastfeeding. And we know that this is fairly obvious, but formula that's reconstituted with PFAS containing water is also an important exposure pathway for young children. So one of the most impactful things that individuals with concerns about PFAS exposure can do is spend some time identifying and thinking about ways to reduce ongoing exposure. So if the PFAS that's detected in a person's water supply is above the EPA's health advisory level or any applicable state or local regulations or advisories, or if it's not and a person's just worried about PFAS in their water, they can consider things like seeking an alternative source of water for anything that would result in ingestion. So drinking water, cooking, preparing food, brushing teeth. There are also filters that a person can use that have been shown to be effective at removing PFAS. So in particular, reverse osmosis and granular activated carbon have been shown to be effective at removing some PFAS if they're maintained and monitored appropriately. We also recommend that people reduce exposure by paying attention to local advisories around fish consumption and the consumption of locally caught game. So there are states, for example, that have advisories around the consumption of locally caught deer or wild turkeys. And so we really recommend that people follow those advisories. There has been a great effort to remove PFAS from consumer products in the last, say, 5 to 10 years. But we still recommend that people be informed consumers and check out product labels and avoid consumer products that may contain PFAS if they're worried about exposures. One of the initial investigations that really opened the public health community's eyes to the extent of the PFAS exposure problem was water sampling that was conducted as a part of the EPA's third unregulated contaminant monitoring rule, which you'll also hear referred to as the UCMR3. This was a rule that required any public water system that serves more than 10,000 people, as well as a large handful of smaller systems, to sample their water and to test it for 30 unregulated contaminants. And that list included 6 different PFAS. So this sampling was conducted between 2013 and 2015. And you can just see a little bit of that data here on the screen. So if you're looking on the left, starting on the left-hand side, there were 51,000 community water systems that were tested as a part of the UCMR3. I'm sorry, let me start that over. There are approximately 51,000 water systems. Of those, 4,800 were tested as a part of the UCMR3. Of those 4,800 systems, there were 129 systems that had any detectable level of PFAS, and 65 that were found to have levels of PFAS that exceeded the EPA's lifetime health advisory at that time. So that represents about 6 million people who were drinking water with levels of PFAS that were higher than what the EPA considered safe. So that's pretty striking. That really got our attention. But what I really want to call your attention to is this number down here at the bottom. If you look at the water systems that were not tested, that represents about 60 million people, so 10 times as many. So this data was really important. It really made us aware, but it really was by no means a comprehensive picture of exposure in this country. Now, as we speak, the EPA is implementing the next iteration of this rule, the 5th unregulated contaminant monitoring rule. They began collecting samples in January of 2023, and they'll continue until 2025. And it's exciting because they've expanded the program. Now they're requiring monitoring for any public water system that serves more than 3,300 people. And they're sampling, of the 30 contaminants on the list, 29 are PFAS. So this data should begin rolling out really any minute. And it should give us a lot more information about where exposure is occurring in this country. Now, I want to draw your attention to this paper down here at the bottom of the screen, which was just recently published, I believe, in Environmental Health Perspectives. And it was an assessment of how that UCMR3 data was representative of public water systems on tribal lands. And so what these authors reported was that in the 3rd unregulated contaminant monitoring rule, 3.2% of public water systems on tribal lands were included in this sampling effort. So there were 27 systems that were sampled as a part of the UCMR3, and that was 3.2% of the public water systems on tribal lands. Now, in the UCMR5 that's going on now, these authors made an effort to estimate how many public water systems on tribal lands will be included, and what they came up with was 12.7%. So that's an improvement. That's great. But I think this really points to the fact that there's still quite a bit of surveillance that's needed. Okay, so I also want to call your attention to a couple of other sources of information looking at PFAS monitoring on tribal lands. What you're looking at here is a map that is available on the EPA's website. You can see that there at the link at the bottom. And this is a place that you can go to find data from the EPA's PFAS drinking water sampling project, which is not comprehensive. It is completely voluntary, but it is one way that EPA is providing drinking water sampling support for water systems that request it. And so I think the last time I checked, there were about 1,000 data points in the system. And you can follow this link if you want to explore. You can filter the data by region or by tribe. So that's a great source of information. There's also some data out of the Environmental Working Group, and you can see their map here on the screen. They did it in, oh, did we just lose the mic? Okay, I think we're back. Thank you. So this is data out of the Environmental Working Group, and they did an assessment of the location of PFAS contamination sites. So this is not water monitoring data. This is the red dots here on this map represent actual PFAS contamination sites. And what they report in their findings was that there are 140 confirmed PFAS contamination sites within 5 miles of tribal lands. And they report that there are 2,815 suspected PFAS contamination sites within 5 miles of tribal lands. And you can learn more about that data there with that link at the bottom. So the potential for PFAS to cause or to be associated with human health effects is difficult to wrap your head around. There is a huge amount of data. And by and large, it all points to the fact that PFAS exposure most likely impacts many different body systems. So in humans, some studies have shown that high-level exposure to some PFAS has been associated with things like increased cholesterol levels, changes in liver enzymes, decreased immune response to vaccines in children, increased risk of high blood pressure and preeclampsia in pregnant women, small increases in infant birth weight, and an increased risk of kidney or testicular cancer. Now, I want to emphasize that studying the potential for human health effects from PFAS is very challenging for a lot of different reasons. Top of mind for me is the fact that there are more than 9,000 of them, and we've really only studied a very small handful. I don't want to get into the weeds on the pharmacokinetics, but another real challenge with understanding human health effects of PFAS is that PFAS behave very differently in traditional toxicology models like rats and mice than they do in humans. And so it makes it very difficult to interpret the findings of traditional toxicity testing in the context of human health. But thankfully, researching this potential for human health effects from PFAS is considered a very high priority. There's a lot of ongoing work going on in the academic world, and I'm going to share a bit about what ATSCR is doing on that front as well. So ATSCR is actively involved in PFAS sites all across the country. And you can see some of them here on this map. In addition to 9 ongoing research studies, we are conducting public health assessments all across the country with the long-term objective of understanding where and how exposure is occurring, determining the relationship between exposure and human health effects, and ultimately identifying and implementing strategies to prevent and reduce exposure to PFAS. A lot of our funding for our PFAS work comes through the National Defense Authorization Act, which primarily funded ATSCR to conduct 3 activities: the multi-site health study, the exposure assessments, and the PEAS study. And I'm just going to go through this quickly because I'm going to talk more about each of those in just a second. Okay, so first up, I'm going to talk about these somewhat in chronological order because that's what makes sense to me. So I'll start with the exposure assessments. These were statistically based biomonitoring investigations that aimed at measuring PFAS in the blood of 10 different communities across the country. So these 10 communities were primarily, exclusively, really, communities that were located near either current or former military bases. That was due to the language in the authorization that I just mentioned. And the thinking there is that these facilities likely used a specific kind of firefighting foam that contains PFAS. So we conducted these exposure assessments across 10 different sites, and we measured PFAS in the bodies of over 2,000 adults and children. We've now released individual results to all of those participants. We've also released individual site reports for all 10 of those communities. And we've also released a final aggregate report that combines the data across all the sites. If you're interested, there's a ton of information in those reports. If you're interested, they are all up on our ATSCR website. You can see that link there at the bottom of the screen. Overall, the key takeaway messages from the aggregate data analysis were that average age-adjusted PFHXS levels in the blood of participants were higher than the national levels in every community that we looked at. We also found that the average age-adjusted levels of PFOA and PFOS were higher than the national averages in just about all of those communities. Our assessment indicated, not surprisingly, that those elevated PFAS blood levels were likely the result of past drinking water contamination in those communities. We found that there were some demographic and lifestyle characteristics that were linked with higher PFAS blood levels. And I also want to mention that while these were biomonitoring investigations that primarily focused on measuring PFAS in blood, we also collected a few tap water samples in each of our communities. And all of those tap water samples were below, the PFAS concentrations in those samples were below the EPA's 2016 health advisory, which was what we had at the time, as well as any relevant state levels. There were 2 tap water samples that had concentrations of PFOS that were above one of ATSDR's health-based comparison values, but all were below the EPA lifetime health advisory. Okay, so this is just a little chunk of the data. What you're looking at are the measurements for each of those communities for PFOA in comparison to the most recent available data from the National Health and Nutrition Examination Survey, also known as NHANES, which gives us a sense of what levels look like in the general US population. And again, this is PFOA. You can see in navy and in green, these are the ATSDR-led EAs and our pilot EAs. And this yellow bar, that's the NHANES data. And so you can see that for all but 3 of our communities, levels were above what we see in the general US population. And these 3 at the bottom that were below were actually quite similar to what we see in NHANES. PFOS is very similar. Again, we have the NHANES data there in that yellow bar, and you can see that all but 1 of our sites were above the NHANES levels that we saw in the general US population. And in fact, one of our communities was significantly higher. That's the Airway Heights community in Spokane, Washington. And then finally, I just want to show you the data for PFHXS. Here you can see that every community that we went to had average age-adjusted levels of PFHXS that were higher than what we saw in the general US population. Here you can see that the average age-adjusted level for Airway Heights and Spokane, Washington was 65.6 parts per billion compared to 1.1 part per billion in the general US population. And again, all of this data and all of our conclusions and all the guts of this report, all available online if you want to check it out in more detail. Okay, so next I'd like to talk a little bit about our multi-site health study. So this is different from the exposure assessments. Our exposure assessments were biomonitoring investigations. They were only aimed at measuring PFAS in blood. They were not trying to understand the relationship between those blood levels and health effects. The multi-site study is kind of like the next step. The primary goal of the multi-site health study is to understand the relationship between PFAS exposure and health outcomes among different populations. We're conducting the multi-site health study through cooperative agreements with 7 different partners who are working in 10 different communities across the United States. And you can see those here on the map. But I want to note that the findings from this study will be relevant and helpful for all communities that are facing contamination to PFAS in the drinking water, not just the communities that are actually included in the study. So in addition to measuring PFAS in the blood of the participants in the study, the multi-site study will collect information about immune response, lipid metabolism, kidney function, thyroid disease, liver disease, glycemic parameters, and diabetes. We're hoping to enroll at least 2,100 children and 7,000 adults from the selected communities. And I'm happy to report that all of our sites are underway with their sample collection and their recruitment. I believe we actually have 2 sites that have completed their sample collection and recruitment. And in addition to that, the teams are also working on fate and transport modeling to historically reconstruct what the water levels would have been like in these communities in the past. And they're also conducting pharmacokinetic modeling activities to predict what the historic blood levels may have been in the participants in the study. Okay, so next I want to talk about the PEAS study, which is a study that we are finishing up in Portsmouth, New Hampshire. The PEAS study is the first site of the multi-site health study. It really was our pilot site. And specifically with this community, we are looking to see if PFAS exposure leads to high cholesterol, lower vaccine response in children, specific diseases related to changes in the liver, thyroid, and kidney function, increased risk of high blood pressure or preeclampsia in pregnant women, greater risk of ulcerative colitis, and ADHD in children. So participant enrollment for the PEAS study concluded in December of 2021. So that's all wrapped up. And I'm happy to report that all of the samples have been analyzed and all participants have now received all of their results, both their PFAS blood level results and also their clinical results. So now CDC and ATSDR are in the process of analyzing that data and preparing reports and manuscripts for the peer-reviewed literature. Okay, so with that out of the way, I now want to switch gears a little bit and talk about some of the resources that ATSDR has available to support communities with concerns about PFAS exposure. So one thing that we hear all the time when we go out into communities with concerns about PFAS, we hear all the time that people are going to their doctors and asking questions about PFAS, and their doctors have never heard of PFAS. They have no idea what they're talking about, which is understandably a very frustrating experience for these people. And so to address that concern and to provide information and resources to clinicians who are seeing patients with concerns about PFAS exposure, ATSDR developed this overview of the science and guidance for clinicians on PFAS. So for patients who come in with concerns about PFAS exposure, the most important component of the patient visit is really identifying and reducing current sources of environmental exposure to PFAS, as well as promoting standard, age-appropriate preventative care measures for general health and wellness. So things like the Bright Futures and Clinical Preventative Services guidelines. Now, for people who come in who are asymptomatic, who have no symptoms, but who know that they've been exposed to PFAS, this document does not suggest any deviation from established standards of medical care. For patients with signs or symptoms of disease, this document recommends that those symptoms be treated, but that they be treated using the established standards, the same treatments that would be applied regardless of PFAS exposure. The document recommends that clinicians follow the National Heart, Lung, and Blood Institute's guidelines for pediatric cholesterol screening, regardless of PFAS exposure. And there also is no recommended change to the immunization schedule for children. Oh, and I should mention, let me go back. You can find that document on our website under the resources section. Now, more recently, in an effort to improve that guidance for clinicians, ATSDR partnered with NIEHS, the National Institute for Environmental Health Sciences, to enlist the National Academies of Science, Engineering, and Medicine to conduct an independent review of the evidence, looking at the human health effects that are associated with PFAS exposure with the specific intention of informing clinical care of exposed patients. Now that report is available. You can go get it online right now. It was released publicly almost exactly a year ago in July of 2022. And it provided really bold advice regarding PFAS testing, PFAS blood testing, and how the results of PFAS blood testing could be used to inform clinical care. We are now, in CEH, ATSDR is now looking at that report and considering its recommendations and the scientific evidence for those recommendations. And we are working on an update to the information that we provide for clinicians so that, will be available in hopefully the not too distant future. But in the meantime, the National Academies report is available online if you want to check that out. Okay, so moving right along, there's another resource that we released in November 2022, so not that long ago, that I'd like to share a little bit about. Another thing that we hear from communities all the time is that people want to know what their PFAS blood levels are. People ask for blood testing all the time. ATSCR does not have the capacity to provide a blood test for every single person that wants one, but we recognize that people have a right to know what's in their bodies. And so to address this concern, we developed the PFAS blood level estimation tool, which is a pharmacokinetic modeling based tool. It's developed as a resource for community members. So it's user friendly, it's web-based, it's housed on our ATSCR website. You can go find it right now. Links there at the bottom. And basically it is designed to estimate current levels of PFOA, PFOS, PFNA, and PFHXS in a person's blood right now today, based on their historical exposure to PFAS in drinking water. I want to be really clear. It's not intended to replace actual PFAS blood testing. It is also not intended to provide any estimation or diagnosis of any potential health risks or any outcomes based on that PFAS exposure. This tool is based on a suite of pharmacokinetic models that we developed for PFOA, PFOS, PFNA, and PFHXS. So these models were thoroughly calibrated and evaluated and validated. They were reviewed and they were peer reviewed, and they are now published in the peer reviewed literature. We published this work as a series of 2 papers. The first is a description of the Bayesian parameter estimation for 2 parameters that the model is most sensitive to: volume of distribution and biological half-life. That paper is out in Environmental Health Perspectives. And more recently, a second paper that describes the model more fully, all the guts, how the parameters were incorporated, the mathematical equations, the validation, all of that. That paper was published more recently as well. So you can go, if you want to dig into the technical pharmacokinetic guts, you can. So to use the tool, the user has to have at least one measurement of PFAS in drinking water. They can be PFOA, PFOS, PFHXS, or PFNA. It can be all 4. It can be just one. They just have to have one measurement. And then they're guided through a series of demographic questions. So they're asked their month and year of birth. They're asked their current weight. For individuals who identify as female, they are asked a series of questions about their breastfeeding and pregnancy history, because we know that pregnancy and breastfeeding are both significant excretion pathways. And then users are provided with their results, with their estimated PFAS blood level in comparison to national averages, as well as information to help them interpret those results and information about the limitations of the estimate. So you can see an example of what that result screen looks like here on the screen. On the right, you see the estimated level, and what the model provides is a measurement of the range that the individual's PFAS serum concentration is expected to fall within based on the information that they provided, along with a central tendency estimate. So we used a Bayesian approach to account for variability, and you can see that represented by those dashed lines. And then next to it on the left, you see that estimate compared to what was actually measured in the general US population in the most recent NHANES sampling. So in this case, we have the 2017-2018 data. I also want to point out at the top, the user is provided with a headline that just provides a very quick, short little snippet that quickly explains how their estimated level compares to the general US population. So next, the users are provided with a little bit of information about what they can do next. What should they do with this information? And what you'll notice if you play around in the model is that regardless of the estimated level, the recommended next steps are the same. And so we really recommend that people who use this tool learn more about their current exposures. We recommend that they talk to their healthcare provider, voice their concerns, that they review the information that's available from the EPA about the existing health advisories. We also recommend that users of this tool take steps to minimize their future exposures to seek out water testing if it's needed, to install filtration if that's appropriate, and to avoid other sources of PFAS. And then finally, we also recommend that individuals make an effort to learn more about PFAS in their specific community. And so we provide resources that can help a person do that. Now, before I move on, I do want to reiterate that this tool is based on a model with inherent limitations. So I think it's really exciting. I hope that this tool is really useful for communities, but it does have limitations. The tool cannot definitively say what a person's PFAS blood levels are due to information that just can't be captured by the tool. For example, each individual is going to excrete PFAS at a little bit different rate, which of course is going to impact how much of the PFAS remains in their blood. We also know that people are exposed to PFAS in many different ways, not just through drinking water. So this model is designed to account for those non-drinking water exposures with a generic background term, but it can't be modified to reflect individual scenarios. So if a person, for example, eats a lot of fish from a water body that is known to be contaminated with PFAS, the model can't really account for that specific exposure pathway. I also just want to really emphasize that this tool is not intended to replace PFAS blood testing, and it's definitely not intended to guide clinical action. I'll also say that this is just the first iteration of this tool. We're really excited about it and expect that there will be future versions in the future that are an improvement on this tool. So we hope to include additional PFAS as the data becomes available to support that kind of modeling, and make other improvements as we get feedback from users. Okay, so now I'm going to move on to our tox profiles. One of the most important things that ATSDR does is produce toxicological profiles, including the one that we have for perfluoroalkyls. So tox profiles are, we develop tox profiles by congressional mandate, and these are absolutely comprehensive collections and summaries and interpretations and assessments of all of the available toxicological and epidemiological literature on a given compound. And so you can find the link to the tox profile for PFAS there at the bottom. And I'll mention that it was released in May of 2021, but it is currently already there is an update underway. So when there is sufficient data, ATSDR develops what we call minimal risk levels, or MRLs, which are an estimate of the amount of a chemical a person can eat, drink, or breathe each day without a detectable risk to their health. So these are doses. They are developed for non-cancer health effects, and they can be converted into drinking water concentrations for both adults and children. And those drinking water concentrations in this case are called environmental media evaluation guidelines, or guides, I believe it is. So these are just tools that ATSDR develops to help evaluate sites that are looking at PFAS contamination. Neither MRLs nor EMEGs are action levels. They are not cleanup levels. They are certainly not regulatory levels. They are used as a screening tool. So they are a way that ATSDR's health assessors can evaluate exposure at a site and really determine whether additional work, additional evaluation is needed. So like I said, the tox profile for PFAS is currently being revised and updated. There's new literature, there's new science coming out all the time. But at the moment, these numbers that you see here on the screen are the MRLs and the EMEGs that are published in the current version of the tox profile, as well as the critical studies and endpoints that these values are based on. Now, you'll notice that all of these critical studies are toxicological studies that are conducted in rodents. I want to just speak briefly about our process, especially given what I said earlier about the challenges of interpreting toxicological data in the context of human health. So to develop MRLs, ATSDR first scans the epidemiological literature to identify the sensitive health endpoints that are of concern for the given chemical. We then go to the tox literature and identify studies that establish a dose-response relationship for that identified health endpoint. We then identify what's called a point of departure. So that's going to be a serum concentration or blood concentration for each of these PFAS that's associated with an effect in the tox study. So usually in a rat or a mouse, we take that point of departure and we convert it to what's called a human equivalent dose, which is based on the assumption that the blood level that caused the effect in the rodent is likely to also cause an effect in a human. We then take that, the human equivalent dose, and we apply uncertainty factors, and that's how we land on our MRLs. Now, we also, as I mentioned, we also developed EMAGs, which you can see here on the screen. We use these EMAGs, in the case of PFAS, we use the EMAG for children as the initial screening tool in communities with PFAS contaminated drinking water. We also consider whether the water contains PFAS for which we don't have these kinds of comparison values. Like I said, there are often many different kinds of PFAS in the drinking water. So we have to consider how exposure to a mixture of PFAS might be impacting human health. Ultimately, ATSDR's health assessors combine the findings from both the qualitative and the quantitative assessment in order to draw conclusions about the risk to human health and to make recommendations for further action. Now, the focus of this presentation has really been on ATSDR's work around PFAS, but I do think it's important to acknowledge the broader landscape on PFAS. There is a lot going on with PFAS right now. It's kind of having a moment, you could say. And a lot of the work that's going on in other places really impacts the communities that ATSDR serves. In particular, I want to call your attention to a few comparison values from the EPA that ATSDR has recently started using in our own site evaluations. So EPA has published health-based comparison values. These are called reference doses for 4 additional PFAS. So that's PFHXA, PFBA, PFBS, and Gen X. And so these reference doses have been finalized by the EPA and they've been incorporated into ATSDR's public health assessment site tool. As a general policy, ATSDR does not use values from other agencies unless they have been finalized. So you may have heard in the news or out and about that EPA has recently released health-based comparison values for PFOA and PFOS that are really low. Those values are not yet final, but if and when they are finalized, ATSDR would incorporate them into our site evaluations. I'm going to stop there. Thank you so much for your attention. I know that was a lot of information. I'm happy to take any questions here in the room. I also have my email address up here on the screen. There it is. And I just want to encourage you to please reach out. I'm happy to chat about these chemicals. I talk about them all day long, whether the people I'm with like it or not. So I'm always happy to answer questions. Please feel free to contact me if you'd like to chat more or ask questions now. Anything online? Okay. Indeed.
A lot to take in as well.
Yeah.
But it's really important, all of these Ps. So it is overwhelming, right? But first of all, thank you for your work and trying to take what appears to me a very complex and data heavy and putting it into a presentation that I almost understood. So PFAS, before we get to the Bs and the Gen X's or X-Gen and all of the, there might be a Z and I don't know. But the timeline for the regions, you had a map up. I don't know if you can go back in your slides where you had the US map, not the hotspot map, I'll call it the hotspot map, but you had where you had blue And those were the regions that you had tested and et cetera, right?
Yes.
And then towards the end, you said where data is available.
Mhm.
So tying to the places that you have not tested and where data is available is where you include it in the mandated congressional report.
Right.
And report for the public's use.
Yeah.
Do you know a timeline for all regions, given the high rates that were tested? And mostly, of course, for me, I am concerned about earlier in your presentation, and again, thank you. You talked about the red spots, right? And how they were within 5 miles of tribal communities.
Mhm.
We know in tribal communities, and later you linked it, you said there may be a link to liver, kidney, diabetes. I mean, it was almost like a rhythm in your voice, right? Of all of the various things.
Yeah.
And so I'm wondering if you happen to have a timeline, not that you can project out. And of course, we have to get funding from Congress in order to carry these out. But with our partners, which of course are our sovereign nations, our states, our local health departments. I'm thinking how, given a timeline, how can we try and help with that timeline? So personally, I'm part of this, citizen science, right? So I count the butterflies, right? And I put that in and I spot how many cardinals and I put that in, right? Now, I don't think we as community members probably have the expertise to do some of that. And I certainly don't know how many nonstick cook pans and some of those other things that are directly connected. And then there's the indirect where it breaks down into the soil and the water and et cetera. So how can we help, Rachel, besides the pen to Congress that all these PPs going on up here on all these slides are really important. And then we have to have funding to do that because there is potentially a direct connection to some of the causes of some of our high rates of these health disparities. So again, I wanted to thank you for putting such a complex data into a way that I am on the edge, the very seat edge of understanding. And this is my first exposure to this, although I did make myself a note to go get a blood test for PFAS. So thank you very much for your presentation. And how can we help?
Yeah, I love that question. Thank you so much. Like I said at the beginning of my talk, I've been working on PFAS at this agency for over a decade. And one thing that really stands out to me from that time is how important the role of the community is. So for example, we're currently conducting a multi-site health study that I expect to be groundbreaking in terms of our findings. I think it is going to, I think the findings from that work will be so critically important to our understanding of how PFAS may be impacting health. We're also conducting the PEAS study, which is similarly impactful. That work wouldn't be taking place without the involvement of communities. I think that I have seen time and time again that when communities care, when communities voice that care, when communities participate, when they get involved, and when we listen to them, that's when the work gets done and it's happening. I think we see it happening. I think to your point about timelines, it's not happening as quickly as maybe we would like it to be, but it is happening. And I think that while, I talk about PFAS all the time and it can feel really doom and gloom, I think there's a lot of hope that we can draw from that reality. I think that we have seen that when communities get involved, the work gets done. And so, I think that's the biggest thing. I know that our findings from our exposure assessments would absolutely not have been possible without the participation of the communities that we serve. Sometimes we ask for things that can feel very burdensome. Giving a blood sample is not insignificant. Filling out a questionnaire with personal information about your life and your choices is not insignificant. But without those things, without that participation from the communities that we work in and that we work with, the data and the findings and the science wouldn't move forward. And so I think those are some of the things that we have evidence are already helping and will only continue to help moving forward. Any other questions? Okay. Yeah, sure. Yeah.
Very interested in the work you do with community engagement. So
Mm-hmm.
I love your visuals. So I took a couple of pictures. But what I wanted to find out, you're going to have all this data and you are, of course, going to disseminate it back to the communities.
Yeah.
How do you make sure it's in a form that it will be readily received
Yeah.
and can be applied in their daily use?
Oh, I love that question too. Thank you so much. There's so much really groundbreaking research around communication of data, especially very technical scientific information back to communities. One thing I showed some screenshots from the PFAS blood level estimation tool, the results and what can you do next and resources. All of that information was crafted with the support from the Silent Spring Institute, which I think just does amazing work around biomonitoring report back and scientifically understanding how we communicate things like biomonitoring results to communities that are very tuned in and very engaged, but maybe don't have a PhD in chemistry, and so they really advocate for a layered approach that allows people to access information as they're ready for it, as they want it, and to dig deeper if they're interested or to set it aside if they're not. And so we've really tried to incorporate some of those approaches in our own work. I think there's a lot more to do there as we're conducting these really large studies with lots and lots of people. I think there's more work to do around report back and around communication of this very technical information. But I certainly think that the agency recognizes the importance of that and is making really great efforts to always be improving in that way.
Thank you, Richard, for your great presentation. Whenever I venture talking about PFAS in public, the first question I get is, what is it that the people in charge are doing to remove those products out of the market?
Mm-hmm.
Because if they are in the market, people are going to use them and contaminate bodies. So just share with you my concern and what is it that you have heard that the government is doing to help out.
Yeah, that's always a challenge. I think staying ahead of the introduction of these kinds of chemicals into the environment is very challenging, especially at the federal level. I can't speak in detail, but I can tell you that EPA has developed a roadmap that is very broad. It has lots of different pathways on it, but they have specifically targeted quite a bit of action that's aimed at reducing the use of these compounds in consumer products, reducing the import of these compounds into this country. There's also quite a lot going on at FDA around the use of PFAS in food packaging materials. So I think that ball is rolling. There is momentum building. The challenge, of course, is that as we phase out the use of PFOA and PFOS, for example, there's always a replacement that's being queued up. And so it's this devil we know versus the devil we don't know. And so that, we could talk all day, but I think that it's important to keep in mind that as we identify these chemicals of concern and make important steps to get them out of commerce and to reduce exposures, there is usually another one coming down the line. And I think it's very important that we not lose sight of that as well. Okay, all right, thank you.
Thank you, Rachel, for that very inspiring and detailed and thorough presentation on PFAS. Always say everything you want to know about PFAS, but we're afraid to ask. Ask Rachel Rogers. All right, thank you, guys. All right, we are headed forward with our agenda, and I am happy to present the next set of speakers. Safe water, sanitation, and hygiene in Indian country. Access to safe water and adequate sanitation and hygiene facilities are basic needs for health and well-being. Always say you gotta have water. Many communities, including American Indian or Alaska Native communities, will continue to lack access to these basic services unless progress increases. Representatives from CDC's National Center for Environmental Health and ATSDR and EPA will discuss problems, technical assistance with water, sanitation, and hygiene interventions that can address problems with private drinking water systems. These interventions include building capacity to identify hazards through inspection of drinking water and wastewater systems, responding to and preventing outbreaks, and filling crucial functions during emergencies such as testing water supplies. I think we'll have our first presenter from EPA, Jonathan Reynolds. Jonathan is from EPA Region 6. He will be presenting virtually. So we'll pause and get him set up and ready to present. And then following, we will have our very own Troy Ritter from NCH ATSDR. I want to just read just a basic bio, short brief. For Jonathan Reynolds is a life scientist that has been with EPA Region 6 for almost 3 years in the drinking water section. He is currently the regional contact for inorganic contaminants, capacity development, operator certification, and the backup state program manager for Texas. Before joining EPA Region 6, he attended Virginia Tech to earn degrees in water resources and forestry. Troy Ritter, who will come right behind Jonathan, is a water system subject matter expert at CDC's National Center for Environmental Health. I've had the pleasure and privilege of working with Troy, I don't know, for almost 2 decades, if you will. I'm not telling our age, Troy. His duties include managing an interagency agreement with between CDC and the Indian Health Service Division of Sanitation Facilities Construction. Before transferring to CDC, Troy spent 16 years working with IHS and Alaska's tribal health organizations. Without further ado, we'll start with Jonathan and we'll follow up that with Troy.
Hi, good afternoon. I am not able to share my screen, so I can either get started while that gets figured out, or we can hold off until that gets sorted out.
So are we able to help manage that from the back? I'm just wondering. Why don't we start with Troy? Would that be okay, Jonathan?
That's fine.
Oh, just try it. They said you might be good to go. Want to try it for a sec?
Yep, I got it. Give me just a second to get set up here.
Okay, great. How we doing?
Okay, are you all able to see
Okay,
my screen?
yeah, we can see it. Looks good.
Perfect. Well, then, good afternoon. My name is Jonathan Reynolds. Like you mentioned, I'm with EPA Region 6 Drinking Water Section. And today I wanted to discuss Safe Drinking Water Act and how it's implemented in EPA Region 6, especially in our tribal nations. So just as a brief overview of the Safe Drinking Water Act, shortened as SDWA, it was passed in 1974 originally, and then amended twice in 1986 and 1996. The Safe Drinking Water Act authorizes EPA to set standards for drinking water, and it also authorizes EPA to set monitoring schedules and frequencies for various systems. These monitoring frequencies may differ from system to system depending on the specific situation. And there are some water systems that will be monitoring for unregulated contaminants, such as manganese and PFAS. The Safe Drinking Water Act authorizes the regulation of public water systems. These are water systems that are serving 25 people or more for 60 days or more out of the year, or have 15 service connections. Under CIDWA, the EPA also created and enforces the National Primary Drinking Water Regulations, and this sets those monitoring schedules that I mentioned. In Region 6 specifically, EPA directly implements all drinking water regulation over the tribal nations. Some of the tribes are regulated by Oklahoma Department of Environmental Quality instead of EPA, those inside of Oklahoma, obviously, but a majority are regulated by EPA directly. And in Region 6 of those regulated by EPA, every water system receives a sanitary survey at least every 3 years. For those regulated by ODEQ, it may be up to 5 years, but it's typically going to be within 3. And so I primarily wanted to take this time to just discuss sanitary surveys, because this is our most direct route to see what is going on in a water system and assist the water system as possible. There are eight areas that we look at in a sanitary survey. First, we have the source, then treatment, distribution system, finished water, the finished water storage, sorry, the pumps, monitoring and reporting, management and operation, then operator compliance. Once the sanitary survey is complete, the surveyors have the opportunity to identify significant deficiencies, and they set corrective deadlines. Under the groundwater rule, for any system that is served by groundwater wells, they have 120 days to correct any significant deficiencies identified. And under the surface water treatment rule, water systems have 45 days to correct them if they are served by surface water. One caveat to this is that as long as they do it within that time frame, they can get an extension and they can be on an approved schedule that can go beyond the 120 or 45 days. But the extension has to be approved within that time frame. And just one note that a significant deficiency in itself is not necessarily a violation. It's when they go outside of that allotted time frame. Okay, so starting out with a water well. We are the water source. What we're looking at is the integrity of the well, making sure that the well itself is going to be able to maintain service, that there is still a sanitary seal, that there is no pathway of contamination to the well water itself. We look for the wellhead being at least 18 inches above the ground for any new construction and modifications, as well as a well pad around the wellhead. This ensures that for the 18 inches that they, in any case of floodwaters, the water cannot go over top of the wellhead and thus create a pathway for contamination. For a wellhead, it's similar in that any runoff, we're wanting the runoff to go away from the well rather than straight down the well into the aquifer below and thus contaminate the aquifer. Okay, so now I'm going to go through some pictures, and for each one of these I have some pictures for us to look at. And what we're seeing here is that green thing that you see in the top right, that is the wellhead with the lock over top of it. What we see here is the well pad, and there is clear erosion underneath the well pad. And the concern that we have with this is that water can flow underneath the well pad and follow the well all the way down into the aquifer and contaminate the well with surface waters. Next, we have a similar issue. You see a pipe on the left corner of this wellhead. First of all, the wellhead doesn't look fantastically well maintained. You see a lot of corrosion there on the wellhead itself. But in the lower left, you see a pipe a conduit going through the well pad. With this, we have concerns of water going into that conduit, and we don't know where that conduit leads, likely just to the underside of the well pad, and thus creating a pathway for contamination. Now, some systems will choose to abandon their wells after they stop producing water, or they just generally don't need them anymore. What we see here is an attempt to abandon a well. However, under that metal circle that you see in the middle is just a pit. This well was not properly abandoned. It was not plugged or closed in any way, and offers a large threat to contamination of the water source just by water entering it directly, since there's nothing keeping water out of it. Next, we see a wellhead that is clearly shorter than the 18 inches that we look for. Again, the issue that we see here is that any kind of flood water will easily get above the height of this wellhead, and thus present issues with contamination. Next, we have operator compliance, and of course the picture is covering that there, but that is okay. Here we have operator compliance, and what we're looking for is that the operator is licensed, and that the operator is licensed to the level of the water system that they are operating, as well as that the operator is competent to be able to continue operating the system that they are over. What we see a lot of times is that someone comes out to a water system and sells them this big fancy water treatment system and says, we'll come out and do the maintenance on it and everything. And then the operator has no clue how to actually run the water system. And so we see issues with the operator being over their head in the system that they are in charge of. Issues here are that the operators are adding chemicals to the drinking water. So we'd like to ensure that there is a level of competency and they are not inadvertently harming the population in the drinking water. Next, we have treatment and finished water storage. This is making sure that the appropriate treatment is being applied to the water, not too much, not too little. That treatment is being properly maintained consistently as water is being produced. Ensuring that the integrity of the storage tank is being maintained. The tanks should be inspected every 5 years. And then we're looking at the vents of the water tanks. All tanks are going to have vents to some extent, but we would like these vents to be screened to prevent any kind of vectors from entering the tank itself. So here we have a mixing tank for some sort of water treatment. This looks like it's probably a fluoride tank. But what we have is a large hole there that goes straight into the mixing tank, presenting a pathway for bugs or anything to get into that tank and get mixed in with the solution, and therefore get into the finished water. Next, this is an overflow line from a water storage tank, and that is a dead bird that is lodged inside of that overflow line. Likely what happened here was the bird actually got inside the tank and got into the overflow line through the top vent of the tank itself. Excuse me. Here we have a bat that was found in a very similar situation. In these overflow lines, not only are there issues of stuff getting into the overflow line from the inside, of course, the overflow line should have a rubber gasket on this little cover that you see on the top that flaps in and out, allowing water to push it out, but generally stuff will stay out of it. And then we also would like to see these and other vents screened with 24 mesh. This will keep different types of vectors from getting in there and preventing contamination. Next is another picture from an overflow valve that had mesh on it, but not so much anymore. And we would like this mesh to be repaired. Next is what can happen in a storage tank if it is not properly maintained. What we believe happened here was that there was some oil that was used in the pump for the wellhead that had leaked into the water, and therefore the water got into the tank. In this case, they would likely have to drain the tank in order to properly deal with this situation. But they were able to see that there was an issue just because they were inside the tank looking around. Next, we have some extreme erosion. We talked about the integrity of the water storage tank. In the top right corner, you can see where the tank is, and you can tell that this hillside is rapidly eroding and threatening that water storage tank itself. Next is a distribution system. Distribution system will have some air relief valves throughout to release some of the air in the distribution lines, or in the mains as well. And so these air relief valves will have a valve, of course, that lets the air out, or a vent that lets the air out. And we would like to see that vent above grade and screened. Typically we'll see that in a vault, but we need it to be above grade to prevent any issues with potential flooding. We'd like to see that there is appropriate chlorine residual throughout the system. We like to avoid any major leaks or intrusions into the system, and we want systems to know generally what material their lines are currently in the ground. Here we see an air relief valve that is in a pit, in a vault, and clearly below grade. Next, we have a water line that was in the ground for quite a while. This is actually a wooden water line, and those have been out of commission for a very long time. So your guess is as good as mine of how long that has actually been in the ground, and I know for a fact that they don't know either. Next, we have a line that is leaking. Leaking lines can present issues with the pressure of the system, as well as if water is going out, what else is going into the line. There's a threat of contamination through that break itself. Next, we have a list of some chlorine residuals being monitored throughout the system. And sometimes we see some inconsistencies. So here we see a 3-day gap and then a 2-day gap later in the measurements. And then we look over and see the results on the right. We're seeing 0.2, 0.0, 0.0, 0.04, 0.06. 0.2 is the absolute minimum that we would like to see. Preferably a little higher than that, but they were below this for a little over a week. Next is pumps and pump facilities. We're looking for any leaking pumps, any sanitary seal issues, making sure that all the pumps have the necessary gauges and whatnot, as well as making sure that the area is generally safe for people to work in. So here we see some leaking oil in a water pump. Here we see some oil that is getting to the lower end of what's supposed to be in there, as well as based on the color, it looks like it has reached its lifespan. Here we see a pump that is heavily corroded, as well as looks to be leaking a lot of water out into the environment. And this is a peristaltic pump that will put chlorine into the water, and it is just haphazardly installed onto the side there. We would like these to be installed properly so that they do not have a chance of falling or failing throughout the system. And then cross connections. Cross connections are the opportunity for water to be contaminated due to a loss of pressure, creating a suction event in the water line. And so some of the main issues that we see with this are hoses. So in this picture here, you see that a hose is leading straight into a chemical tank. And if there was any kind of loss of pressure within the system that created a vacuum event, what would happen is that chemical that's inside that tank would actually be siphoned out and siphoned into the water system and sent throughout the distribution and or sent into the water storage tank, contaminating the water source. To prevent this, we like to see an air gap, which is the height that we like to see in that air gap. We like to see 2 times the diameter of the line that is producing the water over top of anything else. And then there's also atmospheric vacuum breakers that can be installed onto hose bibs to prevent any backflow during a siphon event or a vacuum event. Next, we have operational safety. This is ensuring the safety of the operator as well as anyone else that might happen around the system. So the first thing that we see is a storage tank for some chemicals that has no secondary containment. And so if there were to be any kind of failure of this storage tank or this storage tank of chemicals here, that chemical would spill all over the ground and it would cause an issue for anyone around, including the operator who needs to get there to take care of it. Here we have a variety of chemicals that are being stored together, and we have concerns of the incompatibility of these chemicals being stored together and what would happen if there were any kind of mixing between these. Next, we have a vault that has some different valves here. And the operator went in to try to get to one of the valves, and they found a handful of snakes on top of one of the valve handles waiting for them, which is less than ideal. And finally, we have the water system management and operations. We want to make sure that the system is being well maintained, that all the standard operating procedures are being followed, and that the facility is clean and safe. So here we see a standard that was being used to for water monitoring, and we see that it expired in August 12th, and then on the right we see August 2012 and June 2011 or 2007, and these were very expired when the operator pulled them out for us to survey at the time. And here we see just a whole mess in the background, but also on the ground, you can see a bunch of droppings of different animals and whatnot, all around the water system, creating a concern for the water system itself, but also the operator. Now, before I wrap it up, I just wanted to add that when these issues are cited at a sanitary survey, EPA has the opportunity and the resources to assist these water systems as much as possible to help them to correct them and continue serving safe drinking water to their public. Are there any questions? Okay, well, thank you very much.
Good afternoon. Sorry, talking about water is easy for me, but using microphones and clickers is really hard. So hopefully I can get this correct. All right, well, this is nice. Got a set up. So in today's presentation, I'm going to provide just a brief overview of CDC's tribal water and sanitation activities. But before I start, I want to talk about a partnership that I do much of my work through. In 2016, I went to my boss at Indian Health Service and I said, I've been here for 16 years. I want to do something different and I'm leaving and going to CDC. And he said, well, if you leave, who'll do your work? And I said, that's your problem. And so then he said, okay, smarty pants. And he picked up the phone and he called my new boss at CDC, which he had hired into the public health service about 35 years earlier. And they wrote this agreement so that I could continue doing my IHS work as a CDC employee in Atlanta, along with my other CDC responsibilities. So I guess that shows me it always learns you a good lesson. It's a small world. But this agreement is between CDC's National Center for Environmental Health and the Indian Health Services Sanitation Facilities Construction Program. Now I'm what they call an EHO, an environmental health officer. And this program is mostly engineers. So what I do here is provide an environmental health perspective to construction activities and to help the engineers not just build things, but build them in a way that provides a maximum health benefit. So what's going to be covered today? I'm going to briefly summarize 5 activities that CDC is doing to benefit tribes and tribal water and sanitation. I'm just going to jump right into that with the first one here. Now, the first activity I'll talk about is a long program. We've been doing this since 2015, but what's going on here is we are estimating the impact of sanitation infrastructure construction on disease prevention and healthcare dollars saved. Now, before this program, it was well understood what the costs were. Construction in Indian country costs a lot of money, but what are the benefits? What's the other side of that coin? So this is basically a modeling approach that uses 3 disease classes: acute respiratory infections, skin infections, and infectious diarrhea. And each year we produce an estimate of the number of diseases prevented, as well as the number of healthcare dollars saved or avoided through that treatment. As well, since 2020, those estimates that I produce go into the Indian Health Service's congressional justification, so that not only are they requesting the funds, but they're able to provide an estimation of the benefit, the impact of those funds. Just to kind of go to the main point here, what we estimate in historically is that $1 spent on water and sanitation construction in Indian country yields about $1.18 in avoided healthcare expenses. So that's a great return on investment. Now, I don't want to go into the methods of how we do this too much. If you really want to know about it, call me up. We can talk for hours. But what I would say is this is a translational approach where we started with really understanding the impact of one. What's the impact of having water and sewer versus not having it on one person or one home? And then we translate that to larger populations and other areas, and accounting for other factors that might influence the relationship. There's 2 important data sets here. I use sanitation data from the Indian Health Services Project Data System. Every September, tribes are applying for money and funding for water sanitation projects to Indian Health Service. They score those out, decide which ones they're going to fund, and then forward that list to me, and I provide health estimates for them. Health data comes from the National Data Warehouse. I don't take possession of any personally identifiable information. The rate reductions that I use here: respiratory disease, 16%, skin infections, 20%, diarrhea disease, 38%, these are done through research, a body of research that that's been accumulated with Alaska Native American Indian populations over the last 10 to 12 years. And I assume that the infrastructure is going to last, once built, for 30 years. I'm not going to go into this in detail, but this shows capital expenditures, water and sewer costs. But what I want to show here, maybe the third column, you can kind of see what Indian Health Service spends on water sewer construction in a typical year. 2015, of course, the earliest year has the lowest number, about 142 million, 328 million in 2021. This year was a special year, $1.3 billion as a result of the bipartisan infrastructure bill. That money is going to keep coming for another 3 years at that level. So return on investment by year, these are the estimates, and you can see that the return on the investment lowest in 2019, 2%. I would, though I have an asterisk by that to say this estimate was produced in March of 2020. You know, anything else happening in March 2020? You know, we were kind of in the thick of the pandemic, and this information was difficult to get at that time. I'm not particularly confident in that, so I have asterisks it. But between 2% and 47%. Now that's a big range, but the reason that the numbers vary widely by year is there's a considerable impact based on what you're building. Projects that serve a large number of people with a low cost have a big impact. You could imagine, for example, constructing a new water storage tank. Now, the water storage tank benefits all the people who receive water from that tank, but also it's a pretty low cost. Now, I do this by area and then roll it up into one estimate, but I do produce an estimate each year for the Oklahoma service area. And using the 2023 numbers, this is right off the press, I guess you could say, 64 projects were funded this year that serve 10,080 homes and a little more than 32,000 people. I estimate that's going to prevent 47,270 cases of disease. That includes inpatient and outpatient, with an estimated healthcare cost savings of $52.8 million for an 8% return on the investment. Now, in order to calculate return on investment, I'm simply dividing the healthcare cost savings by the cost of the infrastructure. The next project I want to talk about involves operation and maintenance support. Now, I mentioned a minute ago that this is a historic year. The new infrastructure bill provided funding for every Alaska Native American Indian home to have water and sewer construction. But what does that mean? And what are the other consequences of those expenditures? In particular, you know, since 1958, Indian Health Service has been a construction program, the sanitation facilities construction program, and that's been their focus. But what would they become if the homes already had water sewer? Well, for one thing, there needs to be more focus on the operation and maintenance of the facilities. Once you put more infrastructure, you know, out there, you have more to take care of. Now, something that's important to understand is that today government programs, including Indian Health Service, EPA, USDA Rural Development, they will provide funding to provide the initial infrastructure, but they don't fund the operation and maintenance of it once it's in place. It's a really important point to understand. So Indian Health Service is authorized, however, through legislation to provide money that would support the operation and maintenance of the systems. They've just never received funds to do that, but now there's high-level talks to begin. And the Indian Health Service, the new IHS director, asked us to try and calculate, well, what would be the impact of these subsidy programs on the capital improvement project budget? In particular, if you were to provide better operation and maintenance of the water systems, would they last longer? Could you avoid some of the early replacements and repairs of the systems? So that's what I did here to try and understand. And, you know, this year, the year that I looked at here, I believe this is 2022, IHS was spending $350 million. And I estimated that, yeah, providing good O&M would save about $93 million there. Talk just a minute about my general approach. So in order to figure this out, I obtained 1 year's worth of projects. That's about 295 water sanitation projects through the project data system, 2021, I see. And I reviewed each one to try and determine the impact that providing operation and maintenance would have, the impact it would have on that particular project. Some of those could be prevented altogether, some may be partially prevented, and some better operation and maintenance would have had no impact. I want to show here the categories that I placed each into. Now, category 1, these are projects that I determined could have been completely avoided through better operation and maintenance. Some examples, for example, projects to replace leaky pipes. Now, in an ideal world, you have a leak detection and pipe replacement program that's ongoing. And that's a more efficient way to do it. You don't just wait until your pipes leak so bad that they need to be replaced, which is kind of what happens now. Projects need for replacement solely based on the age. As I read through project descriptions, it says, well, we need a new water plant. This water plant is 30 years old. There's no reason that an old plant would necessarily need to be replaced if it had been adequately maintained. I'm going to talk about category number 4. These are the ones that lack enough information for me to really make a determination. So that has to be improved within the data collection system. And category 3 there, these would have no impact. Projects needed to meet population expansion, projects to address engineering deficiencies, projects to upgrade outdated technology. Better maintenance wouldn't have any impact on that. And here you kind of see there in category 1, yeah, about a quarter, about 1 in 4 of these projects might not have been needed had better operation and maintenance been provided. I'm not going to go through all of these bullets, but one of the things that I did with this is provide Indian Health Service with kind of a roadmap to strengthening this analysis. This was a really preliminary analysis, and it was done just by me. So of course, the very first recommendation that I gave them was to build a team of their own folks that could take them through this process, develop a code book, have multiple people score each project, and then have a systematic way to reconcile those differences, and as well as rolling in additional years. This is something that they're going to be doing soon. Now I want to talk about a document that I recently authored with one of my colleagues, John Warren from the Alaska Native Tribal Health Consortium. John and I authored a document called Legionella Risk Management in Small Tribal Water Systems. Now, throughout my career, I've seen sort of 3 phases of water-related diseases of concern. You know, when I started my career, everyone was worried about gastroenteric disease, and that's all we really talked about, and that's what our programs were focused on, was prevention of diarrhea. And then around 2007, 2008, we became interested in water-washed diseases, acute respiratory infections, skin infections, eye infections. And now what we're really talking about and trying to adjust for are biofilm pathogens and how to control for those in water systems. Legionella, if you're not familiar, that's a serious type of pneumonia with a mortality rate of about 1 in 10. So it's very serious. The incidence of Legionella is increasing in the US. Now, there have been numerous resources that have been developed and published to show how to control Legionella risk in water systems, but none of them address the specific issues of tribal water systems, which might have different some different aspects. So This is available. It's approved for distribution. It's right now going through the marketing folks to get branded. It takes a lot to put a CDC logo on something, so that's getting done now. But I'm still able to share the information should somebody want it. Otherwise, it'll be distributed soon. This is a project that I've been working on for about 6 years. It's not finished yet, and I don't know when it's going to be finished, but I have a lot of hope for it. And that involves linking household water and sanitation data with the electronic health record. Now, the idea is to help improve patient diagnosis at the medical center. Imagine a patient presents to their physician, and the physician suspects they might have diabetes, and they are able to look at the electronic medical record and see, oh yeah, this person lives in a home with high arsenic. So this better informs the diagnosis. Now the people within the engineering program of Indian Health Service are very interested in doing this, and we've gotten some good help, especially from the former medical director of the Indian Health Service, to help us move along. But this is a big issue with many structural challenges, and it's just a slow process. I could spend probably the rest of my career working on this, but we hope to get it done at some point. This system would not work in reverse, so no kind of patient information would be shared with the water sewer folks. I want to talk just briefly here about what we call the MiniPass system. Now, MiniPass stands for Miniature Portable Alternative Sanitation System. Alaska Natives and American Indians have the highest percentage of homes without running water and a flush toilet of any group in the US. Now, the difficult thing is many of those homes cannot be served with the existing technologies. We've spent 60 years trying to run a pipe to those homes, and from an engineering perspective, much of it cannot be done. You need to look, I guess what you'd say, outside the box. The MiniPass is a water system, much like you would find in an RV. It has modern fixtures, but there's not pipes going in or out of the home. Now, this is an intermediate level of service. It's not what you would want in the end, but it provides those homes which currently have nothing, some level of service until we can figure out how to run that pipe there. Also important, this infrastructure within the Indian Health Service system is labeled as transitional. What that means is they're still eligible for piped funding. Now, if you take a home that has nothing and provide something there, they're considered served and they go to the bottom of the priority list. We wanted to make sure that that wasn't done here. So these homes are still fully eligible for pipe systems. This gives you a sense of what they look like. There on the left, you've got the home. It's just what they call a honey bucket. It's a 5-gallon bucket with a toilet lid. It's the bathroom and a hand sink for washing. And then on the right side, you have some modern fixtures there. You still have to haul the water in and haul the sewage out, but it's better than before. Quick summary of this. We've installed 205 of these directly through the project. There have been about another 150, 160 that have been installed outside the project with other funds that have been contributed specifically through the tribes in Alaska. So far, this program is only in Alaska. We also provide education to facilitate uptake of that new technology, and we do pre and post interviews to evaluate if it's being effective. Possibly used beyond Alaska, but that's not determined yet. We've got some good partners here, especially the CDC Foundation. Now, the foundation allows us a lot of flexibility. There are a lot of restrictions on what can be done with Indian Health Service funds, especially when you're talking about an experimental approach. But this money comes from a private donor who decided to take a chance on a new technology that hadn't yet been installed. So that was ideal. This is a transitional water point installed in the southeast of the US here. Sorry, desert Southwest, to get my geography correct. This is done in partnership with Indian Health Service as part of the response to COVID-19. Now, early in the pandemic, Indian Health Service got a congressional inquiry that said, what are you doing to help American Indians with the COVID outbreak? Specifically related to water, I think it was mentioned here, maybe Dr. Buchanan mentioned, or someone here mentioned difficulty of washing hands in the pandemic without running water in the home. And of course, that was an issue. So this is what we did to address that congressional inquiry. About 16,000 Southwest Alaska homes lack piped water and toilets, but there's not enough of these water points, places where people would traditionally go to get water if they don't have running water in the home. Sometimes it might involve driving 100 miles round trip to get water. Of course, it's a very expansive area. So what we did here first, we used local health data to help decide where to install these new water points, which is something, the first time and maybe the only time that that's been done within the Indian Health Service program. And as a result, we installed 59 transitional water points in areas of highest need, according to the health data. That reduced travel time overall by about 15 minutes round trip. I am just about finished here. Otherwise, left my contact information here, and I'm happy to get questions now or later. Thank you. Thanks, everyone. I think that's all.
Great. Let's give another round of applause to our two water presenters. Thank you so much. So we're going to take, oh shoot, I don't have my my clock on me, but we're going to take about a 15-minute break, and then we'll finish up today with a wonderful presentation on climate health from our wonderful colleague, Paul Schramm. So yeah, just 15 quick, I'm sorry. Okay, so we're right on track. So yeah, a good 15-minute break. Right. Yes.